Professor Bernard Canaud for second talk. His talk is about cardiac and endothelial biomarkers in fluid volume management of patients.
So you have now another topic, which is, I would say, biomarkers. But the idea is to look cardiac and endothelial biomarkers, the link with the fluid management of the patient, and certainly to identify the risk of the patient. Still the same disclosure. So just to start, I would say biomarkers. I will explain what is a biomarkers. I will concentrate on the serum biomarkers. You have different ways. This morning I was interested to learn about the lung ultrasound. That could be considered as a biomarkers. Biomarker is a marker reflecting a biologic function, so it's not just a lab test. Why CV cardiovascular biomarkers are interesting in a CKD patient, and of course you will understand and how we can use, but what are the limitations of these biomarkers? I will show you some of them. First, when we think about the fluid management of the patient in dialysis, and you do that every day, this morning we had some example. Of course, you start by the clinical assessment and summarized by dry weight, but we have some information about the blood pressure and some element. You have on the machine some tools could be used, particularly the relative blood volume change, which is a nice opportunity. This morning we heard about instrumental assessment, about the lung comets, but you have inferior vena cava, you have bioimpedance, different element. Biomarkers, and I will concentrate on the lab biomarkers. Analytic support, I did not mention, I just show one slide on this element, but this is coming to link all these factors to some artificial intelligence to facilitate the support and the decision of the physician. So, the idea is, of course, biomarkers is a surrogate for the outcome of the patient and a surrogate for the risk of the patient. I will show you in a different element. So the point, you have to understand the biomarker is a measurable characteristic. It's not necessarily a biomarkers in terms of lab test. Could be any indicators of pathologic or pharmacologic. But what is nice now is the biomarkers could be used as a surrogate endpoint. So that means you can have study just validating, I would say, a therapeutic action based on some biomarkers. So it's not necessarily the outcome, the mortality of the patient. This is accepted by the FDA and European, I would say, authorities as an element. So, different biomarkers. I will concentrate on this element, but again, this biomarkers is linked to the precise medicine and try to identify what are the facts or the factors who can be used to improve the outcome of the patient. So now, when we start dialysis, and this is just to understand where the biomarkers could be useful. When you do a dialysis session, you have what we call acute hemodynamic stress. This is linked to the fluid depletion, hypovolemia, hypertension, ischemic injury. But in between the two sessions, and during the interdialytic phase, you have another factors which is called chronic hemodynamic stress, which is fluid overload, hypovolemia, and so on. So that means if you consider the dialysis patient, they are exposed either as acute or chronic, but they are still always in, I would say, hemodynamic stress condition. And the nephrologists try to play with this, I would say, risk. On one side to correct, I would say, the fluid overload and creating hypovolemia. On the other side, need to be very, very precise and accurate to prevent fluid overload, and this lung ultrasound and inferior vena cava discussion this morning was interesting. This is the idea to prevent this element. That means, now if you look on the cardiac side and the vascular side, what's happening? There is a lot of stress coming to the cardiac system and a lot of stress coming to the vasculature of the patient. And of course, if you expose this stress, you create some, I would say, abnormality in the lab of the patient. You know the story, ultrafiltration, as soon as you move to high ultrafiltration rate, you increase the mortality. But why you are killing the patient in this range is not because ultrafiltration is too high, it's of course because you create ischemic, I would say repetitive ischemia of the heart, or the brain, or the gut. And this is reflected also by the intradialytic hypotension. When you get less than 90 millimeter of mercury, and this is a two study, you have, I would say, tremendous impact on the mortality. And again, hypotensive episode. Why they are killing the patient? Because you are creating, I would say, ischemic insult in the patient. So, and this is something could be reflected, I will show you. We know now, dialysis is a quite stressful condition, but it's not only affecting the heart, it's affecting the vascular, it's affecting the gut, it's affecting the liver, affecting the kidney, so everything is affected. And in addition, inflammation is part of the game. So this is why we need to get access to these biomarkers. I just put a list, I don't want to go into detail, but if you look at the cardiac biomarkers, this is a list of elements. You have, according to, I would say, myocardial stress or fluid volume, you have myocardial injury, troponin, particularly you have some byproducts which would be reflecting some abnormality of the heart, and inflammation or oxidative stress. But all these elements, of course, are reflecting some abnormality of the heart coming during the dialysis session. On the other side, if you look on the vascular system, and particularly you know that the first element to be in contact with the blood is the endothelium. And then as soon as you get something wrong, either from a uremic toxin or hypertension, fluid overload, you are stimulating the endothelium and then release a lot of markers. I don't want to go into detail, but each of these elements is reflecting some activity from the platelet, from the vascular homeostasis, from the vascular inflammation, from the cellular proliferation. So, again, among this list of elements, you have to understand what you want to choose and what you want to follow in this patient. Then, what should be known about cardiovascular biomarkers in CKD patient? And then, first is, of course, you have to start with a laboratory and analytical condition. You need to know that all these biomarkers are very sensitive, and then you need to know what is exactly the methodology to make the measurement. You need to have a coefficient of variation, so you need to have information about the dosage. It's not the point to make a dosage, but you have to understand the patient condition. And is it, I would say, patient with a diabetic condition, or I would say some inflammatory status? You need to understand the serum biomarkers, the dosing method and the clinical value, I will show you in a minute. And you have to understand where is the patient. Is it a CKD patient? Is it a CKD patient with stage 2, 3, 4, 5, or on dialysis? And what is the condition? This is very important to understand what is the value of each of these biomarkers. I will show you some examples. Now, if you look at the BNP, and this is very popular, CKD patient, this is a study showing that normal CKD patient, not on dialysis patient. Just to show that on the BNP, you have, of course, different value. This is the normal value. As soon as you move with the CKD, you have an increase of the BNP, and of course, when you go on dialysis, you have different value. Different values, this is, I would say, standard, I would say, chronic kidney disease patient. Now, if you add on the CKD patient cardiac, I would say, abnormality, systolic or diastolic, you have a different profile. So that means it's almost impossible to understand what is the value or the predictive value of the BNP if you don't know what is the status of the patient in terms of kidney function and what is the status of heart functionality. So meaning that BNP is quite interesting, reflecting some abnormality coming from the CKD progression, but also from the fluid and from the cardiac status. Just to show different, I would say, study. If you look at the BNP and you look with this, I would say, diastolic index or wall stress, which is reflecting the volume, you see that you have a nice relationship, meaning that BNP is expressing one fluid overload of the patient. Okay, that's fine. But on the other side, if you look on this, the BNP is correlated to the left ventricular mass. So for the same parameters, you have two types of information. One is a fluid status reflecting, I would say, the wall sphere stress, but you have also the mass, which is reflecting, I would say, muscle remodeling of the heart. So same value, and again shown in a different study. I will show you in a minute. Now, if you look on this, I will see type of BNP. Is it a BNP or N pro BNP? Because you can have this step element. What is the main, I would say, interest? Is it more sensitive on the other one? Same story. Non-dialysis patient with CKD dialysis patient, I will show you in a minute. What is interesting, of course, you understand now, kidney function declining from the normal kidney function to the, I would say, very low stage 4 or 5. You see that there is an increase of BNP, but you can see on the other side that the same trend for NT-proBNP. So the message is clear. If you are using NT-proBNP, it's the same information that you get as a BNP. I don't know what is the cost of each of these markers, but you can get the same type of information. The idea is not to have a duplicate value. Don't do BNP or NT-proBNP. Look with your lab what is the best, or what, but still you get the same trend. Maybe if you look on this slide, a little bit more accurate for NT-proBNP, but I don't want to go into detail. What is the clinical value in practice for managing the fluid of the patient, and what is the serum biomarkers? The idea, which is when you use these biomarkers, is of course to get information about the diagnosis, to monitor the patient, to have prognosis information, pathophysiology, understanding, treatment effect, and to support the decision. Then, meaning that of course, based on this element, you can use the biomarker as a tool, diagnostic, or a quality control tool, or risk stratification, or pathway to understand what is wrong with the patient, outcome surrogate, and precise medicine. So at the end, biomarkers could be used in a different way, different perspective, but certainly I will show you in a minute. It's very interesting, for example, to have a risk stratification of this element. You know this slide from, or these pictures, puzzle from St. Michael, which is fine. So if you look, I just extracted so many biomarkers, but you know, some are reflecting endothelial dysfunction, inflammation, fluid overload, remodeling. I don't want to go into detail, but to show that each of these elements could be useful. This is coming from Canaud, Tassin, and you know that in Tassin they are very restricted for the fluid status of the patient and are drying the patient. But that's interesting from this study. They look in incident population, 50 or almost 50 patients. They start starting dialysis, and what they observe is of course BNP. And you have a distribution of the BNP, which is completely, I would say, abnormal, but you can identify that from the black one, this is CKD patient end stage with a cardiac disease, and this is non-cardiac disease. So you can have a distribution, you have overlap over there, but meaning that you can almost immediately identify the patient with a cardiac abnormality starting. It does not mean that you don't have to drive the patient, because if you drive the patient, and after, I would say, a certain time, if you drive and you look after 3 months, you can reduce BNP. And this is almost the normal value for BNP in dialysis patient, and this is the value of BNP in a cardiac dialysis patient. Meaning that this is reflecting now the remodeling of the cardiac structures and not reflecting, I would say, fluid overload. Just to show what they do, within 3 months, this is the BNP, and you can decline, but you can identify within this group of patients what are the patients with the cardiac status and what are the patients without any cardiac status. And then, if you look what's happened 3 years after, you have a tremendous, I would say, differences between BNP and the mortality. If the patient keep a very high BNP value, you know that the mortality would be very high. So it's risk stratification and a way to understand where are the patients. It was confirmed by different study. I don't want to go into detail. ADMA, this is coming from asymmetric dimethylarginine from the endothelial. And again, look what's happened with the ADMA. You can use the ADMA to identify within the cardiac abnormality what is eccentric hypertrophy or what is a concentric hypertrophy. Is it important for the patient? And what is the sensitivity? You can make rock analysis, it's quite sensitive. But the idea which is behind is, of course, to understand what is associated with the left ventricular mass on the left side and the ejection fraction. So on the left side, you can use ATMA to identify what is the remodeling aspect of the heart, and you can have some correlation that I want to say perfect, but still significant. And on the other side, you can identify the abnormality of the, I would say, functionality of the heart in terms of ejection fraction. And that's the point, and then I didn't put the slide, but you can identify what will be the mortality in this group of patients. So it's very important to understand what is in terms of, I would say, prognostic value. Now, we heard a lot about the cardiac study, and you know that the cardiac study is coming during the dialysis session with hypotension, hypovolemic status. This is associated with some abnormality of the contractility of the left ventricular or the different, I would say, segment of the heart. This is reflecting myocardial infarction or ischemia. But again, if you just apply to this element, you know that this cardiac study is correlated to the fluid overload and correlated to the ultrafiltration rate. So if you apply different treatment to the patient, from the standard treatment on the left to the nocturnal hemodialysis, you can reduce tremendously the ultrafiltration rate. You know, it's easy. But what you also can reduce is the number of segments affected by this abnormality, abnormal motion of the segment, meaning that you can correlate less ultrafiltration with less, I would say, cardiac event. You can correlate to the variation of the blood pressure. This is fine. But certainly what is the more interesting aspect is, of course, you can correlate with NT-proBNP as a fluid, I would say, markers of the fluid overload of the patient, and you see you have completely different profile if you compare the nocturnal hemodialysis on the right side versus standard hemodialysis. But more impressively, you can look on the troponin T, which is reflecting this ischemia, almost normal in the nocturnal hemodialysis versus, I would say, three times a week standard, I would say, dialysis session, where you get a tremendous ischemic insult of the patient. So, you have a parallelism between the ultrafiltration rate and, I would say, the ischemic insult of the heart. Again, what is now the value of troponin T? So you have troponin T, troponin I don't want to go into detail, but again, if you look on the different study, if you look on this population of dialysis patients who are not developing, I would say, stunning, so that means they don't have any abnormality detected by the echocardiography versus patients who develop this stunning repetitively during the dialysis session. But if you look in this population, you see the troponin T, and you have a completely different profile. Of course, you have a distribution which is not completely Gaussian. You see the average value is 0.6, I would say, but you have tremendous large distribution, and you will see that this large distribution is reflecting, I would say, patients who are stunning. If you look over the time, stunning segment never patient. Sorry, it doesn't work. So on the right side, you get, I would say, troponin T in a patient who never gets stunned, so that means they don't have any, I would say, abnormality, versus a patient who gets stunned. And of course, you will see in a minute that will affect tremendously the mortality. So again, troponin T, for example, in that case, is a way of understanding how the patient is suffering from ischemia during the dialysis session and what would be the outcome after 1 year. Again, it's a different study, troponin I, same information. You see during the dialysis session, beginning and end of the dialysis session. If you look on this 90 patient, 1/3 of the patient get a tremendous increase of the troponin I. So meaning that 1/3 of the regular population gets some ischemia during the dialysis session. And certainly, this certainly will affect the long-term process of the patient. If you look on the mortality, look what's happened. When they get, I would say, increase of this troponin I, so mortality is increased by 25% as compared to the all, I would say, population. Meaning that, based on this element, if you identify the patient who gets an increase of this troponin I or T, you can identify the patient who will die, and that, in that case, certainly they will die from diastolic abnormality. Troponin T is a fantastic, I would say, marker for risk stratification, and this is again from different studies showing that if you look the value of troponin T in your patient, you have a tremendous, I would say, 4 quantiles from the lowest 0.001 to the highest 0.10. Look what's happened within less than 3 years in the mortality. You have a mortality rate which is almost 40%. So stratifying the patient initially and looking what's happened in the patient over the time is an opportunity. Again, troponin I versus in this patient, if you look on the survival, you get, I would say, tremendous, I would say, cutoff showing that the patient are at risk. Is it now troponin I or troponin D? I don't have, the distribution is almost the same, but the point is, of course, do we have to move on this, okay? Do we have to move on troponin? I'm sorry. So if you look on left side and troponin T and right side troponin I, you see that at the end you get the same type of information. So there is no way, if your lab is doing T or I, you can use what you want. In terms of, I would say, predictive value, you will get the same type of information. And again, systematic analysis in the literature shows that troponin T on the outcome is a very strong marker for the risk of dying of your patient. So just confirming this element, same troponin I, same information. So again, if you want to identify the risk for your patient for ischemia and I would say major cardiovascular event, you can use one of the troponin. The new one is a copeptin. I don't want to go into detail of this element, but the copeptin is a sort of precursor for the arginine vasopressin. And this is the only one who can reflect hypovolemia. And again, if you look at the kinetic during the dialysis session, you see that more you drive the patient and then you reduce copeptin. So maybe playing with BNP and copeptin, you can know exactly where the patient is in terms of, I would say, fluid overload, or where is a critical hypovolemia. The idea was to make critical hypovolemia, combining, I would say, troponin I and copeptin. And the last step is, of course, to combine, if you want to enhance the predictive value, with a multi-marker approach. And of course, if you look on pro-BNP, anti-pro-BNP, you can have information about the risk of the patient to die of dialysis. You see the value, 3 decile. Now, if you look on CRP, you know the story. 3 decile, you can identify the patient who can die. If you look on the T and troponin T, same design, you can identify the patient. And of course, now if you combine all these elements, you have